Then I would like to continue with the presentation of Dita Heiberga. She is the director of the Center for Disaster Medicine of the State Emergency Medical Service of Latvia. She has been working at the center for over 10 years. As delegated representative of Latvia, she participates in EU-level working groups on health risk management, as well as represents Latvia in the NATO Joint Health Group. She became the head of the center in January 2020, just before COVID began. And since then, you have been involved in the management at national level. Thank you so much, and success with your presentation.
Thank you very much. At first, I have to warn you that this is a first time when I will use a microphone during my presentation. So if it's going terrible, please just wave at me, and I will leave this somewhere else. So as already was said, my name is Dita Heiberga. I'm and the one leading the Center for Disaster Medicine, which basically is the center or institution who is responsible for health preparedness planning, health sector's preparedness planning. And yes, I took over this position just before COVID-19 hit the world. So basically, my first 2 years in this position was 24/7 work with COVID-19 related questions. And I heard in the audience that there are several of you who mentioned that you have been involved in COVID-19. And but as Oscar Wilde wrote, that what fire doesn't destroy, it strengthens. So I strongly believe, and I'm confident, that we who have survived the COVID-19 pandemic, today we are much stronger, better prepared, with more experience. And I really also want to thank the organizers for the opportunity to share our experience in, let's say, health sector preparedness planning. During my presentation, I will go through and focus on three main terms, which also are very often used in Work Package 6. And these three terms, I believe, are well known to you. One of them is all-hazard approach, intersectoral operability, and I also will try to give you let's say, a small introduction on tools we are using to actually collect data about critical healthcare resources. But before I'm going to my presentation, I just wanted to also explain and introduce you with our service. So we are State Emergency Medical Service. And basically we have four main functions, one of which is ambulance care provision. So we are unified ambulance care or pre-hospital emergency medical care provider in Latvia. So we basically are a little bit less than 2 million inhabitants. So we only have one institution who is providing pre-hospital emergency medical care. Another important function for our service is also we are responsible for organizing trainings in disaster medicine and first aid. We also are responsible for stockpiling national reserves. And the function most reliable today's topic, our center, Disaster Medicine Center, is responsible for preparedness planning for the health sector. And that's why I believe we are here today able to actually share our experience on how we dealt with COVID-19 and what lessons learned we have gained. So in our system, the public health emergency preparedness and response is called Disaster Medicine System, just for your clarification. And what is also one thing I would like to stress out, that in our country, we have been working for a long time now that we are trying to integrate this civilian healthcare system into the plans and procedures which also cover civil protection and national defense. So when we are talking about who is responsible for, let's say, support planning for military, that's again, that's our institution. So we work closely together both with the civil sector, which is most common, but we also are involved in the, let's say, collaboration and cooperation with the national armed forces. The main document in our state in Latvia. It's called the National Disaster Medicine Plan. That's the main document which actually describes the roles and tasks for healthcare institutions during emergencies. And what is important that we actually use in a preparedness planning all hazard approach described by the WHO. We have done that for last 10 years, and so far it has worked for us. What I would like to stress out that again, something maybe specific in our country is that, of course, we have this generic part, which describes the elements of disaster management and healthcare, which are the same despite the hazard. But we also have hazard-specific response algorithms and protocols. We also have a lot of recommendations inside this plan for the hospitals, how to develop their own hospital preparedness plans. And also this plan allows our center to request information about critical healthcare resources, which are all over the, let's say, health sector. And again, I put down this small picture. We just recently in 2021, we added a new annex, which actually is annex about the response during military conflicts. So it's mostly developed for civilian type emergency management, but it also includes parts which are classified, of course, but describes how our, let's say, healthcare sector will work during military actions. The WHO all hazard approach is not the only one we are using. Of course, we are following the guidelines developed by EU, WHO, but I would like to stress out that actually, and I strongly believe that this should be the next step, that we should, as let's say, EU member states, and most of us, we also are NATO allied countries, we should start to look how we can also implement in our preparedness planning the guidelines coming from the NATO perspective. As I mentioned, I'm also a representative of Latvia in the NATO Joint Health Group, and there are many similar topics being discussed also in this format. And I believe that we should start to integrate not only the WHO recommendations and EU approaches, but we should also look how the NATO perspective can actually, how we can benefit from these requirements, which are coming from NATO's perspective. This slide is not for reading, but I just wanted to show that there are different levels of crisis management in a health sector. And of course, the first and the lowest level is the institutional. So in healthcare, in our sector, each hospital which provides emergency medical care has their own internal disaster management plan, and also each service which is subordinated under the Ministry of Health, we have obligation to develop our own response plan. And only when the situation or emergency is cannot be managed by the institutional level, then we are involving this state operational medical committee, who is the highest decision maker in health sector. And actually, there are representatives from all healthcare, let's say, health sectors branches, starting from funding, National Health Service, state medicines agencies, representatives, etc. And during COVID-19, basically for the first 3 months, almost 100 days, we met each day, sometimes twice a day, and sometimes, and of course, during weekends as well. This committee was the one who actually coordinated how the health sector should prepare for this unknown threat. But also what COVID-19 taught us, that actually the health sector cannot be in charge or cannot fully be in charge in situations like this. And during COVID-19, we actually also used this level, that the crisis management or this highest level was involved, and this is led by Prime Minister. And what is also important, that our health sector's plan is only, let's say, it's only describes the health sector's part in the response. But as I said, there is strong linkage and interactions between the two other plans, which is civil protection and national defense. By saying this, actually, I already mentioned that COVID-19 was something else. We actually were not able to manage the COVID-19 crisis only in the health sector. We needed to involve many more other sectors. So I want to share our experience, and I call this the story about 1 million masks. I don't know, maybe you can raise a hand who remembers the times when we were fighting about the procurement of masks. And who of you have been involved in the procurement of masks? Can you raise a hand? Anyone? Oh, you lucky guys. So that's not my story. So I was unfortunately involved in this task. So yeah, all countries, even the largest one, were fighting about the possibility to gain and procure masks. So I will shortly tell you the story. So our Ministry of Health tasked two institutions, one of which was our institution, to procure 1 million masks. A situation in our health sector at the time was critical. We didn't have enough reserves. Our healthcare personnel was poorly protected, and we needed to do something to actually be able to provide the continuity of services in health sector. So we received this task, and it happens in 3 years ago to 2020 in March. So luckily enough, there was a private company who actually said that, okay, we will do that. We will help you to buy the masks. And they said that they have actually a known manufacturer in China who has 1 million masks, and they will be able to provide us with these masks. If this would be the end, this would be happy story, yes? Unfortunately not. After a while, the manufacturer informed the private company, the buyer, that, okay, yeah, you will receive the mask, but you are in a very long waiting list. So it will take several weeks, even months, to get the masks to Latvia. We didn't have so much time. And again, the private company actually also was a very patriotic guys who actually started to, let's say, put some pressure on the manufacturer, and they actually tried to explain that the situation is critical, that the masks are not gonna be, let's say, put on market, that they will be going directly to the healthcare personnel. And the manufacturer actually replied that, okay, if you want to change something, you actually have to involve government. They said it, we did it. So we involved our Ministry of Foreign Affairs. We actually contacted our embassy of Republic of Latvia in China, and we got them together, and our representatives of embassy actually convinced the official authorities in China that this is essential for Latvian healthcare, that this 1 million mask procurement is something very essential for us. And we got the green light. Yes, we moved up in the line as a first, and we received the, let's say, the masks. But again, the story is not so easy. So at that time, during end of March, actually the airports in China, they were working in heavy overload. And our private company said that actually they just cannot find free cargo airspace. So there are no free cargo space in airplanes going from China to Europe where we could put this amount of masks in. So they said that they can, of course, deliver masks in small packages by using DHL or something like that, but it wasn't good enough solution for us. So, of course, we went to the Ministry of Transportation in Latvia. We have our own national airline company, Air Baltic, maybe some of you know this one. So we actually flew the plane there. We decided that it will be easier to get the plane to China than to wait in the line for the cargo space. And we got the masks to Latvia. Almost happy ending. Then we had to involve our state national reserve system because we had to find a place where to stock these masks. And then again, another challenge, how to distribute this amount of masks to more than 100 receivers. We didn't have this kind of experience. The state reserve system is built to provide assistance either on the site of accident, either to the hospital who will receive the most patients, etc. But we had now a new challenge, how to distribute across country 1 million masks in several days, because we had to split the masks like 20, 40, 60 in very small amounts. So we involved a lot of other institutions. We involved almost all municipalities. We got agreement that they are coming to our warehouse with their own transportation and that they are actually helping us to distribute the masks further in their municipalities. We used our ambulance service cars, which were for technical reasons, not, let's say, fit for emergency medical care provision. We used fire rescue vehicles and we used hospital vehicles. So everyone was involved to get the masks as soon as possible to those who needs them. And actually, yeah, and this story actually is not about the procurement of 1 million masks. It's actually is a story about intersectoral operability. And never ever before COVID-19, we in our healthcare preparedness plans could imagine that to procure masks, we should involve everyone inside Latvia and inside somewhere else, maybe the embassies. So again, a great lesson learned by doing this procurement. And now we see that, yes, when we are thinking about health sector's preparedness planning, actually, we should look broader. We should try to imagine the imaginable. What should else we include in our preparedness plans? So this was the story about the masks. And this is the lucky masks standing in the airport in China. And the company actually wrote United Together. The company is together with the people of Latvia. So we received this picture while waiting for these masks to be put in our airplane. There is another story, if I may. I call this story the story about counting beds. So during COVID-19, our service, my center, we were responsible for actually collecting the information about the available beds, the beds let's say beds available for COVID-19 patients, etc. And before I go further, I would like to also for you to think, do you know how critical assets, critical resources are actually tracked in your in your countries? Is it one institution? Is it divided between different institutions? Are there even list of critical data which should be collected? How it's done manually? Is there IT solutions? So for us, for me and Indra as well, I think the first several months went by looking into hundreds and hundreds of Excel sheets. We were trying to find the best way how to collect data from hospitals, about their available beds, about their available oxygen tanks, about available, let's say, PPEs, etc. So we spent a lot of first months looking in these type of Excel spreadsheets. And we had the feeling that this will not work during the COVID-19 pandemic. And luckily enough, we actually were able to develop completely new solution in our healthcare system, which is a centralized online system where hospitals enter and update information about their key resources. And actually, this was already the first version was launched in October 2020, so not so far in the COVID-19 pandemic. And it the first costs were like 10,000 euros, like basically nothing. It was private company again who just agreed to do as a service because they saw that, okay, we are really trying to develop something, but we didn't have the knowledge, we didn't have the skills, and we just got lucky because there was some smart private IT company who decided, okay, we will give you some sort of first version of system that you are willing to develop. And we developed a system which is now called CIRIS. This system, I also presented this system in a NATO Joint Health Group. And this is something quite unique, not only in EU, but also in NATO countries. But of course, we understand that this system works for us because we are a small country. We are a very small country. So, and what are the, let's say, the objectives for this system? Actually, this system allows us each morning, or if we decide more often, receive information from all emergency medical care hospitals about the available beds, available ICU capacities, and etc. And this system also allows us to exchange the information with hospitals. It's not like a chat box, but it allows us to send out the message, and hospitals can send official, let's say, reports about issues happening in the hospital, which will afterwards, let's say, affect our ways how we hospitalize patients. And this system also actually is very useful for enhancing preparedness in hospitals, because we use this system to collect information about different kind of resources, not only the beds, but also about the oxygen capabilities, about the, let's say, generator capabilities, etc. And this sort of system also allows us to, let's say, assess the level of preparedness of those hospitals who are involved in this system. And basically all emergency medical care hospitals are involved in this system. And what is also important that, but we only have 42 hospitals. So if you are from large country, you know that the number of emergency medical care hospitals in your country will be much larger. So, and also we have like 4 institutions who can use the data from this system and who can access the data. It's our service, it's our national CDC, it's our national, let's say, health service, and also, of course, the Ministry of Health. But they are mostly just looking at the system and not, let's say, using the system every day. And there you can see the categories, resource categories in this system. And there is almost 20 different type of categories. And for example, the best part is also that we can develop new categories and include these in our system. For example, the last one was the Ukrainian patients in our hospital system. So we wanted to know where are there any, and if are, where are there, what are maybe the specialization for their treatment, etc. And as I said, we as a unified ambulance provider, we are also the only one who are providing the hospitalization of patients. So by using this system, we can actually also alert hospitals if something is happening. If there's a mass call event, for example, is there any problems with the aircraft during the landing time, then we can actually send out the report to hospitals. Please update your free available bed information or whatever is necessary for us to manage the situation. And the system works both ways, so we can receive up-to-date information from hospitals about their available resources, which can be dedicated to concrete emergency. And this is how it looks. So basically the yellow part of the screen is different kind of reports from hospital. For example, the CT has been broken down, and so we have to change our hospitalization ways, etc. And of course, you can choose whatever other type of data you want to see in the front page. But this has been a great asset for us, both in preparedness planning and also in management during emergencies, by managing the situations. I'm actually now close to the end of my presentation, but I just wanted also to stress out some of the resource categories we have included in the system. And you can see that there is a part where it's written power generators. For example, I don't know if other countries also collect data how hospitals are able, or are they able to provide their alternative energy in times of there maybe cyber attack on the energy infrastructure. So we also collect this kind of information. We also collect information about evacuation resources. Just recently, we had a flood in one of the largest cities, and we had to evacuate hospital due to the risk of flooding. And we used this system to see how many resources for evacuation are available, etc. And actually also in the part where it's other resources, we just recently added new part. We ask, do you have shelters? Do you have basement? If the basement can be actually used for sheltering patients, etc. So this system is not only something which has been developed for COVID-19, it now has been developed and still are improved to be for all hazard approach. And it has been a very useful. And in the end, again, as I said, I truly believe that we should look, as a next step, look into also the NATO guidelines and NATO planning perspectives when we are thinking about how to strengthen also EU, let's say, joint health preparedness. And I just would like to stress out that this is not something new. Actually, after the first Russia's invasion in Ukraine in 2014, in 2016, during the Warsaw Summit, actually the NATO allied countries already agreed that we should focus on strengthening the civil side of our countries. And by saying that, they actually said that there are 7 critical services, critical sectors, which should be actually strengthened. And one of them is health sector. So I believe that we should look also on the health sector as a critical service provider, and we should advocate for health sector as that, because without health sector, any other sectors, or let's say, so as mentioned before, many other sectors will not be in need if there will be no possibility to save the life of our inhabitants. So, and again, another perspective on health care in public health emergencies is not we are critical service provider, but unfortunately, by being critical service providers, we have become also the target for those aggressors who don't follow any rules. Now the healthcare institutions actually are becoming also the target. So I don't want to end my presentation on this note, but I would flip it over and I will encourage everyone here, and also we do it in our country, that we should do everything that we can actually to build better, more robust, more resilient healthcare sector. And we should do this in a manner that we are taking in consideration all hazard approach. And by all hazard approach, I encourage you to not forget about the threats or the situation which is now happening also in Ukraine. So I really like this saying that the only thing more difficult than prepare for an emergency is actually explain why you didn't. So I thank you for your attention, and I will be able to answer if there is any questions afterwards during the coffee break. Thank you very much.